Well, good morning, everyone, or afternoon, depending on where you are joining us from. We are so grateful that you could be here today for our deflection panel. Hopefully, everybody has gotten logged in and is able to see the screen that's ahead of you now. It should say deflection panel. My name is Kate Vesley. I am the Director of the Justice Services Department, and I want to introduce my co-facilitator today, Sergeant Jason Winsky with the Tucson Police Department, who's the supervisor of the Mental Health Support Team at Tucson Police Department. We're going to start off giving you guys just a little bit of background information on what is deflection and a little bit about how our services operate here locally, a little bit about the Justice Services Department, and then we're going to get to the real important stuff, our wonderful, amazing panelists, which we will introduce at the end of just a couple of slides and let you all hear from them today. So thank you again very much for joining us, and we'll go on to our next slide here. So I can't do anything before thanking everybody who worked on this project. Special thanks to Shannon and her amazing team at Justice System Partners. At the very beginning of the pandemic, we were approached about participating in this research study that has been funded by the MacArthur Foundation as part of our Safety and Justice Challenge. And Shannon and the amazing folks at Tucson Police Department and Connections Health Solutions worked very diligently through very challenging times to collect the data, conduct interviews, do a lot of research, and so everybody who put a lot of time and passion into this work, I'm very, very grateful for all of your efforts. Thank you. Next slide. Just a little bit about Justice Services here. We are a new department in Pima County as of July 1st. We have been working in the MacArthur Safety and Justice Challenge for several years now through county administration, but we have a lot of other projects that we're super proud of and dedicated to, and including our efforts around justice system reform. We are trying to do a number of different strategies that not only support our justice system partners, but improve outcomes in the justice system, utilize our taxpayer resources the most efficiently we possibly can, while transforming the lives of our community members and hopefully the next generation of our community members while we're at it. Some of the goals that we try and work toward is safely reducing our jail population through strategic interventions like targeting individuals who have mental health and substance use disorders who present a low risk to the community safety. One of our core values here is addressing racial and ethnic disparities, and we have a separate grant with the MacArthur Foundation to address disparities in our criminal justice system. We want to improve those outcomes in the justice system. We want to increase resources like housing, transportation, access to treatment, employment, and we certainly want to expand capacity with our justice system partners. And of course, we live here. This is our community. We want to make our community safe for everyone. Next slide. So just a couple of our projects here. I won't take up time talking about any of these, but if anybody's interested in learning more about anything that we're doing here, any of our projects, just more about how you can get involved, we really champion community involvement in the work that we are doing. So please don't hesitate to drop us a line at justiceservices@pima.gov, and we would love to talk with you more about what you're interested in seeing from this work. Next slide. Folks look at some of the services we have and wonder, oh my gosh, how did this happen? But it was not an overnight project. And credit to Dr. Balfour, who put this amazing slide together. We have had quite the evolution here. I want to give some acknowledgement to both the Tucson Police Department and Pima County Sheriff's Department. The Sheriff's Department started the first mental health support team here in Tucson and Pima County back in 2012. Tucson Police Department followed shortly thereafter. And then about 4 years or so, 3-4 years after that, Tucson Police Department also implemented their substance use response team, the CERT team. We've had multiple projects. You can see it started out little things happening largely in response to some negative events, and then year upon year we've added more and more, and we've built upon that foundation that we have started. Obviously, we got started here very recently, and just this year we launched our Reroute project, which is the race equity cohort strategies that we have been working with our MacArthur Foundation partners on. Next slide. All right, so what is deflection? And it wasn't, I think we were among the very first communities anywhere in the country to start really utilizing this term uniformly. A lot of communities use the term diversion, but we have a lot of diversion programs here in the court system as well. We needed something to signify skirting somebody away from the justice system altogether. And so diversion in our community typically means law enforcement encountering somebody who has substance use and mental health disorders. And for eligible individuals, for appropriate situations, they are, instead of charging that person, booking that person in the jail, they are rerouting them to an appropriate level of treatment, whether that be substance related, mental health related, but in something in lieu of a criminal offense. Next slide. So we want to really emphasize that this is not just a, we drop somebody off and off they go. That there is a whole intricated crisis system here that deserves its own study, its own presentation. It could be, Dr. Balfour could certainly teach a whole college course on how our crisis system works here. And our crisis system is truly one of the best in the country. Certainly, there's lots of room for improvement and growth, and we could always use extra funding, but the way that we have designed our systems and the way that we have prioritized crisis and our funding has really been a model for other communities across the country who travel here many times a year to understand how we are handling this. So law enforcement is only one access point for the crisis system. People can call, people can have a crisis mobile team, they can walk in, and then after that crisis has happened, there is a whole another network of wraparound services that go along after that crisis has happened. So it's not just a forward over there and hope for the best. There is a whole network of integration that follows behind it. Next slide. And again, I could spend an entire presentation just on some of these resources, but we want to emphasize how much of a village is around our crisis. It's multiple treatment providers, it's managed care organizations, it's our regional behavioral health authority, it's our law enforcement partners, it's government resources like the Pima County Health Department, Pima County Behavioral Health, our jail and Sheriff's Department partners, crisis mobile teams. So there is a lot of integration. There's a lot of cross-system collaboration, coordination, and communication that go into making this work. Next slide. So I will turn it over to Sergeant Winsky to introduce the rest of our panel.
Good morning, everyone. Like Kate said, my name is Jason Winsky, and I'm with the Tucson Police Department, and I'm the supervisor of our mental health support team. I have the pleasure of introducing our panelists today and also asking our first question. So a brief overview of our esteemed panel here. We have our very own crisis systems celebrity, Dr. Margie Balfour, who is the Chief of Quality and Clinical Innovation at Connections Health Solutions. We have Brendan Bond, a peer support specialist at Kodak and one of the founding members of our substance use resource team at the Tucson Police Department. We have Officer Todd Schladweiler. He's with the Tucson Police Department, and he is a founding member of our mental health support team. And we have Lieutenant Erica Strapka, who was the founding sergeant of our substance use resource team and our resident deflection and diversion guru. So we're going to jump right in with our first question, and it's going to go to now Lieutenant Strapka. Congratulations. And our first question is, how is law enforcement trained in identifying and supporting people experiencing behavioral health issues who may be eligible for diversion to places like the CRC or a Kodak Met Clinic? Are all officers trained? And can you give us an overview of how CERT started and just your journey through that whole process?
Thank you, Sergeant Winsky, and thank you, Kate, for the warm introduction. Great question. So the Tucson Police Department takes pride in being able to provide mental health first aid training to all of our officers who come out of the academy. And that first step of training officers to understand how to recognize when somebody is in a mental health crisis really helps us to start that dialogue of saying to officers, this is, we're trying to destigmatize the idea of mental health equals criminality. So it's more about trying to help this individual to get to a place where they can trust us to connect them with the right individuals in the community, our behavioral health partners. That's one thing I'm very proud of with the Tucson Police Department, that we have the mental health first aid training for all of our officers. Then once officers are in the field and they start to get a little more experience, we provide the crisis intervention training. This is a class, as you know, Sergeant Winsky, that's very, very sought after here in TPD because of the great lengths by which the class itself really helps to expose the officers to all the different resources within the community that we can utilize as a referral source when we're up against, a situation where really we know that going to jail is probably not the right outcome for this person, but rather trying to help connect them with a place where they can get treatment. For us at TPD, when we implemented the deflection program in 2018, I have to say, I'm very, very grateful for Kodak, because we were able to take the model that Sergeant Winsky, you and Kate and Dr. Belfour were able to create with our MISS team, and really take that model and implement it in what we were doing with substance use disorder resources and treatment options for officers. Kodak provided us this co-teaching at their facility, where every single patrol officer in our patrol services division attended a 4-hour training at the actual medication assisted treatment center. And that really allowed, once again, to go back to this, destigmatizing the idea of when a person is using substance, that it doesn't mean it's a moral dilemma. It doesn't mean it's something that we should be looking at as this person's a bad person. Rather, we should be looking at it as a situation or an opportunity for us to connect this individual with treatment that can really address the underlying cause. But I don't want to take everybody else's time. That's really kind of I can definitely share more about our training, but those are some of the basics that we provide and have provided to the officers in TPD.
Thank you so much, Lieutenant Strapka, for that introduction and kicking us off. Our next question is going to go to Dr. Balfour. Dr. Balfour, can you give us an overview of what happens when someone goes to the crisis center, what kind of treatment and services are offered there, and then kind of what's the wraparound and what happens as someone moves through that journey?
Sure. So the Crisis Response Center, or CRC, was really designed to provide an alternative for people to get their mental health care in somewhere besides an emergency room or besides a jail. And so the hallmark of it is that it's easy to access. So anybody can walk in, or they can be brought by police, they can be brought by the mobile teams. No one's ever turned away, including people who may be struggling with some really severe agitation or substance intoxication or mental health symptoms. And there's we see both adults and kids, and there's really two sorts of levels of care for the crisis component. There's an urgent care clinic, which is you walk in or come in voluntarily, be brought by police voluntarily or mobile team, who really just need to have a quick assessment, maybe a medication refill, be connected to services. And those folks are typically in and out within a couple of hours. And then there's our 23-hour observation unit. And this is a place where it's really intensive services, intensive assessments. People will get, they see either a psychiatrist or nurse practitioner, typically within 90 minutes. They see a social worker, they see peer supports who are helping them work through their crisis. We're immediately on the phones with talking to families and clinics and trying to figure out, what does this person need in order to get their needs met and hopefully get back into the community. In a lot of other communities, these are people who would typically be waiting in emergency rooms for an inpatient bed somewhere. And our philosophy is, if we really wrap around that person and get that person what they need and start to stabilize them as quickly as possible, the majority can actually be transitioned to community-based care. And that's what our data shows. And we have those services for both adults and kids. For adults who need to stay a little bit longer, we also have a short-term inpatient unit. And then we also can transfer people to any of the different hospitals in town. We work very closely with all of the different clinics like Kodak and and the various other clinics to get the person connected to the outpatient care that they need if they're going to be able to go home.
And I would like to ask a follow-up question to that, Dr. Balfour, because one of the most important things that were included in the report, which we will drop a link to in the chat if anybody hasn't had an opportunity to review that. There was also a link to that report in the announcement of this panel that went out as well. But if anybody hasn't had a chance to see it, one of the most important components that was discussed in there is this no wrong door policy, which has been really a flagship value of our crisis system since almost day one. Can you talk a little bit about more about what that means and why it's so important for our justice system partners in particular?
Sure. In a lot of communities, mental health has this reputation of being difficult to access. And, places will give you this huge list of people who cannot come here, where they can't be too agitated, they can't be too intoxicated, they can't be too violent, they can't be too suicidal, etc. And we want those difficult people because those are the people that are most in need of specialty mental health care. If they went to an emergency room, they'd probably be restrained on a gurney in a hallway. That's what happens in most communities. And so we want them in our specialized setting. We don't use security. It's our own really highly trained behavioral health technicians and our peers who are really managing the unit to make sure everyone is safe and de-escalate people. And because if you don't take everyone, then you end up with the most in need people still going to the ER and still going to jail. So we never turn law enforcement away. We are situated right next to Banner's emergency room. We don't require, in a lot of communities, they say, well, everyone has to go through the ER first, which just makes the problem of overcrowding in ERs worse. So we take people in and we assess them. If they do a very low percentage, probably around, I think it's around 2 to 4%, we may need to send over to the emergency room for a medical evaluation, then we take them back. But anyone who lands on our doorstep, whether they walk in or whether police bring them or the mobile crisis team brings them or their family, they are never turned away. They're always, they get in front of a clinical staff member to start that assessment process. And then we may need to transfer them somewhere that better meets their needs, but we always take them in. We never say, put that person back in the back of your police car and drive off somewhere because you're at the wrong place. And another reason that is so important is the data shows, you may have heard of crisis intervention training, or CIT, which is kind of the gold standard for law enforcement agencies to recognize mental illness and to de-escalate and then to divert to treatment. And it's long been recognized that doesn't work unless you have a place to bring people to, and you need to make it easy for officers to do the right thing. And so that's another reason why one of our most important metrics, I'm kind of a data nerd, but one of our most important metrics is our law enforcement turnaround time, which is we try to get officers in and out in 10 minutes or less. Our most recent data is around, I think, 6 minutes, because it needs to be faster and easier to bring someone to treatment than to jail. And that will make, it's I like to say we figure out how to say yes rather than look for reasons to say no. And we make it easy for officers to do the right thing.
Thank you so much, Dr. Balfour, for that. And I already see some questions coming in the chat. A quick programming note. We're going to have a little bit more facilitated discussion, and we can see your questions coming in. We will answer those at the end. And I already see a data question that I'm going to gear up and give to Dr. Balfour. Our next question is going to go to Officer Todd Schladweiler of the Tucson Police Mental Health Support Team. Can you talk to us? You spent a lot of years now in the diversion deflection space. Can you talk to us a little bit about why you want to do this work and why you support this program?
Sure. There's a lot of reasons that I can think of, but due to time and stuff, I'll try to narrow it down. One thing I'd really like to talk about first is to address the myth that law enforcement doesn't support criminal justice reform. I don't think that's true. I started at the Pima County Jail about 20 years ago, and then the last 15 or so, I've been working with Tucson Police. And from the very get-go, the biggest frustration we had was responding to numerous calls for service that had an obvious mental health nexus, and substance use and homelessness. The quickest way we could resolve those issues at the time were to establish a minor criminal offense and arrest them and move them out of the area that way. And that was really frustrating because we knew that didn't get to the root of the problems. It was plain and simple. It was easier to take people to the jail than to a hospital or for detox. So it was a nightmare for police navigating the different hospital ERs and the different protocols. And more importantly, it was extremely frustrating and hard on the folks we were transporting. It took a vast amount of time to get through. So fast forward a little bit, when I became a police officer and the Crisis Response Center opened up, that was a game changer for local law enforcement. The Crisis Response Center was able to provide a quick and effective tool for police to handle mental health crisis. So that made a huge difference. And that reform in itself there was a huge boost that we were able to get to some of the root causes of behavior and get people the help they needed. A second thing before I address why I support these programs is there's a concept, and I don't know who said it or if it's a phrase, but I've been hearing it the last few years, and I really support it. And I think it makes a lot of sense. And it goes something like this. So if somebody knows who brought this up originally, please put it on the chat. It says if the police are out in the community and they're going to make an arrest on somebody, is it improving somebody's life? If it's not, I think we're doing it wrong. And I know there's going to be some cringes on different sides of the aisle with this, but I think there's arguments for that concept on several levels, logistical, financial, moral, ethical. But a very basic example of what I'm talking about is the police go to a call for service behind a business. There's somebody acting, strange in the business is concerned. We arrest somebody for possession of drugs. Is that improving somebody's life? Are there other resources that we can provide that would improve that person's life? And it's debatable. Now, let's say we respond to the same location and we're able to locate somebody that's selling and distributing those same drugs into the community. If we arrest that person, is that improving somebody's life? The community at large, perhaps? I think there's a good argument there. So there's certainly situations where arrests need to happen, and you can say that they lead to improvements of lives, victims of crimes, the community in general. So one of the main reasons that I believe these programs, the mental health support team, the substance use resource team, the homeless outreach, is effective is that they can demonstrate the ability to apply these concepts of deflecting folks from traditional routes like the jail and getting them into services that they need. It gets to the root problems. Also, another thing that we've been able to do in these programs another reason I think I really support them is we've been able to integrate a collaborative approach using crisis team members, nurses, firefighters, peer support specialists to truly provide a first response and a wraparound service when we make first contact as first responders. And the other thing, why I think this is important, as I have conversations with neighbors, friends, colleagues outside of the workplace, panels and discussions like this, as the community learns about these programs and these aspects, I really think it's going to help going forward to recruit and obtain and locate the folks that are diverse, forward-thinking, innovative, the folks that the community wants representing our police department. And I think that can help to improve lives.
Thank you so much, Todd. Great to hear from you.
And before I move on to the next question, more programming notes. Thank you so much for everybody who's posting the questions in the Q&A. We're already getting excited to talk about some of this. I know that there's a hand raised as well. Our plan is to try and go through the Q&A questions first, and then if there are hands raised, we'll do our best to try and take them in order if there's time permitting at the end. But please feel free to submit any questions you have in the Q&A, and we'll take those in order to the best of our ability, or try and answer them live or answer them in the chat if we can. So I'm going to put Brendan in the spotlight next. Brendan has been a founding member of our substance use resource team, since the very beginning, and he is not only a person who has really changed lives with the work that he has been doing, but he has just been a wonderful spokesperson for recovery in general. So Brendan, I'm hoping that you can speak a little bit to what the impact of the program has been from your perspective, and do you have any success stories that you're able to share, something that stands out for you?
Cool. Yeah, thank you. So when I started in 2018 with Lieutenant Stropka and all the officers, quickly I'll explain. I didn't know what to expect, right? Because behavioral health and law enforcement, we deal with the same people, but we never really worked together before. So I didn't know what to expect when I'm doing outreach and how people are going to respond to me talking to them with a police officer next to me, right? But once we started doing it and working together, the relationship that it has become it's hard to explain, but it's amazing because we have both sides of the story, right? We have law enforcement in case there's any criminal activity, and I'm a heroin addict myself. I'm a recovering heroin addict. I used heroin for 10 years. I've been clean for 8. So I know, I've dealt with police on both sides of the street, and I know how people think, oh, there's a cop, I'm in trouble. Walls go up lit like automatically. But going out with the substance resource team, mental health team, the homeless outreach team, the last 3 or 4 years, the relationship that it's built with the community, between TPD and the community, between social workers and TPD, and just in general, that full circle, let alone the lives that we've helped, not going to jail, not adding all the fines and fees, and getting them into treatment and dealing with the root causes. But the relationship between all of us and then the community, it's just been amazing. And we've helped people that we wouldn't normally be able to help, right? Because if this wasn't a unit, but these officers would be on patrol, and there's a list of things to do. I would be at site calling the regular people, but because we have this unit, we interact with people that probably would have never interacted with, unless they've been to jail 10, 20 times, and then, now they're on our radar, so there's a bunch of different successes, but I'll name one. Well, I'll name a couple. So we met this guy. We go to a lot of tunnels and bridges and parks and stuff and see people. It's crazy how people live. Basically, any tunnel or bridge you drive over, there's probably someone living under that bridge, just so you know. Like literally living with a mattress and but anyway, so we met this young guy. He had a felony warrant, so we had to go to jail, but we did our deflection thing. We shared all our information, and he really wanted to change, but he had this past charge that obviously there's consequences for some things we do. So we had to go to jail, but the officer and I continued to meet this gentleman in jail over and over. We got him into a halfway house. He ended up relapsing again, but we continued to, build the rapport and meet this guy in jail. He got out again. Long story short, he now has his own house, his own job. He got his license back. He's off probation. He got off probation early. And he's having a successful life, and he has kids. He just had another child. His parents are very grateful. The thing is, when we help one person, we're not just helping that person. We're helping like a tree of hundreds of people. Like we didn't even realize we were helping. So this young guy's parents are ecstatic. You know what I mean? His kids' lives are changed forever. Who knows what would have happened if he would have continued. And yeah, it's not only us. Obviously, this guy made the decision to better himself, and that's the main part. But us being able to take the time to see him in jail, to take the time to help him and talk to him and build a rapport, It's just amazing. And then even if we don't get people into treatment, I'll say, because that's like final result, best result, right? Even if we don't get people into treatment, or we just tell them where to go and what to do, just the rapport of like the rapport building of the police with the community. There's a multiple people that are just grateful to have a positive interaction with police, right? Because usually we're going to jail. Usually I'm getting a ticket for whatever. But with all the interactions we have daily with these people, and they're not going to jail, they're being showed love and appreciation and honesty. You know what I mean? We're still being honest with them. Obviously, they're still using drugs or something is wrong, so we're not just babying them, but them having a positive interaction with law enforcement or with behavioral health, because sometimes people hate behavioral health also, right? It's really cool what the program is, and there's a lot to it, but I hope I didn't ramble on and you got something out of that.
No, I
Wonderful,
thought that was
Brendan.
great.
Thank you.
Yeah, thank you.
Cool.
Thank you very much. Very, very powerful for sure. I like the analogy of it's like a whole community of people that you're helping when you help one person, right? Could not agree more. Our next question is going to go over to Lieutenant Strapka. You know, being there from the beginning and having built a lot of this program and programs like this, what are your thoughts on maintaining, you know, accountability versus diversion, deflection? And what does accountability really mean for the person, like what Brendan just described? You know, the decision point between arrest or deflection and, you know, maintaining our, you know, responsibility to the community as law enforcement as well.
One of the things about the deflection program at TPD that was key when it was developed is discretion is something that officers have when they are assessing whether or not a person would be a good fit for being taken to a treatment provider in lieu of either being cited or booked into jail. And part of that discretion and decision-making, that's where we really rely back on our training. And, you know, understanding whether or not a person is ready or not is sometimes tricky because, you know, obviously as a police officer, I have a certain amount of authority that the person is going to look to me and really, they know, you know, either they could be cited or they could go to jail or they could have this opportunity to go to treatment. So I think one of the things I'm really proud of is that we have really tried to use things like motivational interviewing, trauma-informed care, and build that into how officers go about making these decisions, understanding that it's not one size fits all. And if there's anyone that's on this webinar that's listening, that's maybe from an agency that's considering a CERT team, having somebody like Brendan on your team is just invaluable, because one of the things about making a decision whether or not to take somebody to jail or not is having that immediate person who can speak at a level that's not a cop talking to somebody. Like, there's something to be said about that. Like Brendan, I'm sorry, Brendan, I almost wish you weren't on this call so you weren't hearing me like just really, really be so like amazingly in admiration of the work you do. But Brendan has conversations with people from a place of experience. That's one facet of what he brings. But the other is that Brendan has conversations with us as officers from his experience. And that helps to guide us when we're trying to figure out what's the best outcome. I'll be honest, like there were times where I was like, no matter what, we have to take the person to treatment. Brendan would step in and go, you know, Sarge, this guy really isn't ready. And, you know, it's like just that voice, you know, of us collaborating together and really trying to figure out what's the best way we can help somebody in their underlying cause of SUD is there. I'm sorry, now I'm starting to ramble. I'm like, so I really just really want to share that there is this collaboration that us as in Tucson really take great pride in, is that we understand it's not one size fits all, and holding people accountable is very important. And I think understanding that people come into police interactions with oftentimes trauma that we don't understand at the time. If we minimize some of that harm that we cause on that individual by having a positive interaction and one that's offering options for them taking responsibility and getting help, that's, I mean, I would hope that's all that the community would, look for in us as a police department. So I'm going to stop talking. Thank you,
Oh, that was
Jason.
great. No, that was great. I appreciate it. Thank you.
If I can insert a PSA here before moving on to our next question, is how important it is using individuals with lived experience at every aspect of any program. Certainly our deflection program has been infinitely better by all the individuals that not only operate with side by side with our team, our TPD team, but also in the development of this program and every program. I just don't do any programs without lived experience anymore, full stop. Individuals who are affected by a program, affected by a system, need to be at the decision-making table. They need to be in an evaluation aspect, and they need to be on the front lines seeing what we're seeing, because that not only the richness that it brings to the work that we're doing in the community, but also the richness that it brings to everybody who is working on the systems and making it better. So anybody who's thinking about these kinds of programs, I cannot emphasize that component enough. So. All right, well, Margie, we're going to get back over to you. One of the core values of everything we do, in addition to having lived experience at the table, is viewing everything that we do through a race equity lens. And one of our core strategies over the next couple of years, in justice services in particular, but with all of our justice system partners here as well, has been data and disaggregating data, because one thing we really understand is how these systems look different for different historically disadvantaged groups. And so certainly our strategies, and one of Margie's core strategies, has been looking at how these services like crisis, deflection, jail utilization is different for different race, ethnicity, and other groups. So Margie, I'm hoping you can speak a little bit to the recent data that you've been doing, some of the findings, and where we are continuing to go from here.
Sure. And I see there's a question in there about data also, so I'll try to roll that in. So first of all, to Kate's point, is we are always looking at data. And actually, when Connections took over the management of the Crisis Response Center back in 2014, we created an outcome data set or outcome set of data metrics for crisis services, for facility-based crisis services, and published those, which so that we can compare our multiple facilities. And that has since been adopted through the SAMHSA national guidelines, through the National Council and their roadmap to the Ideal Crisis System report. And we work really closely with our regional behavioral health authority, which down here is Arizona Complete Health, in Phoenix is Mercy Maricopa, and we all of the crisis system partners have data metrics that they report, and Access, which is Arizona Medicaid, is actually working on a statewide kind of crisis outcome, crisis quality dashboard. And so I think there will be more data transparency coming soon. And at the national level too, there's a lot of work going on with 988 and the increased funding coming from the pandemic relief plans and things like that. There's a lot of work going on building a crisis infrastructure across the country. People are frequently looking to Arizona as a model because we do have pretty much the most robust crisis system in the country. I mean, everyone always want to complain about your own system that you're in, and there's definitely room for improvement. But if you look around the country, most communities have nothing. And so with all of that to say is that there is a lot of work going on in coming up with standard ways to measure outcomes for crisis services. So more to come on that. To Kate's question about the race and ethnicity, that especially after the summer of 2020 and all of the focus on diversity and equity and disparities, we started to look at our own data, and and we're currently doing a more rigorous research study on it. But just preliminarily, we just said, well, let's take a look at the population that we see at the CRC and look at the, the proportions of, people by race and ethnicity, and compare that to what we see, with the county population. And so what we saw is that if you compare our population to the county, you see kind of an overrepresentation of Black and Indigenous people. So like we see, like the population in Pima County for our 3% are Black or African American, but what we see is 9% of our population is Black or African American. For Native or Indigenous, it's 2% in Pima County, and it's 5% what we see. But if you look at the Latinx population, we're perhaps, quote, underserving them, whereas 29% of our population identifies as Latinx, whereas in Pima County, it's 36% for adults. But then if you look at the jail population, you see that Black and Native populations are even more overrepresented. So perhaps that overrepresentation that we see in our population is making a dent in that. We need to do more research to answer that question, but I see it as probably a good thing that we see, more than the baseline levels in our facility. But then if you look at the Latinx population, they're even more overrepresented in the jail. So it's 42% of the jail is Latinx. So perhaps we are underserving that population, and that we need to, as a community, make sure that we are not, it's always good to, every time there's a decision of, am I going to bring this person to jail, or am I going to bring this person to the CRC? And then for us, are we going to admit this person to the hospital, or are we going to send them home? Are we going to have them under Title 36 involuntary care, or are they going to be voluntary? Every time there's a decision like that, that's an opportunity for bias. And so we need to be looking at our data and to sort of make sort of like a feedback loop going, well, is there a disparity? If so, why? And so that's one thing that we really want to focus on, is especially the potentially underserving the Latinx population. Does that mean that, maybe some more specific outreach needs to be done on those populations, or, just, I don't know. That's the point of data, is you have a finding, and now then you have to go investigate it.
Thanks, Margie. And I think if I could build on that a little bit, I think it's really important to indicate too where we have difficulty measuring certain things in data, because we know with historically disadvantaged groups, with historically overrepresented groups, there is a lot of distrust. And so when we see an underrepresentation or an overrepresentation, we're always thinking about different ways to measure, because if somebody, if a certain population is not going to the CRC, is it because there is a distrust with law enforcement? Is there a distrust with treatment systems? Is there a worry about costs and health care, and I don't have I don't have money to pay for it, not knowing that our crisis services are free? And so one of our system partners, the YWCA, which is our partner with the race equity cohort work, one of their strategies is doing listening sessions and talking with the communities and building trust with the communities to try and get insight into those very nuanced questions. And so we can't measure everything with numbers. Sometimes we have to measure things with conversations, and to have those conversations that involves building trust. And so that's one of the other things that we are really looking at, how best to measure and how we can integrate that into some of the more scientific data we've come across. Sergeant Winsky, were you going to say something?
Yeah, I think if I could jump in really quick, I'm seeing some questions come into the Q&A, and we will get to those. But I'm wondering if I could ask Dr. Balfour just a quick follow-up question, because that'll get ahead of, I think, 3 or 4 of the questions I see in the Q&A. Just a little bit more about high utilizers. There's questions about the quote unquote revolving door. And I know that connections in the CRC has a program for people, early identification of people that are coming back to the crisis center over and over again. And so I'm wondering if Dr. Balfour can speak a little bit to what interventions are available for that population, and how do we track which interventions work?
Sure. Yeah. So so a couple of different things, like as far as what services are available after the crisis. We work very closely with all of our system partners, Kodak, La Frontera, Cope, all of the different clinics out there. But we also work very closely with our regional behavioral health authority, which is Arizona Complete Health, who kind of coordinates the whole system. And there's options such as getting people connected to clinics, getting people in substance use treatment. Hope Incorporated, they run a peer run that's post-crisis wraparound. We have a post-crisis transitions clinic at our center in Phoenix at the UPC that we're planning to bring down here sometime soon, where they get some more post-crisis wraparound care. That said, there are people that come back, and so we've have a program we call Familiar Faces because it's a little nicer than High Utilizer. And we years ago took our, came up with, a data definition of our highest, most frequent patients. And then we do a rolling list every month, and we work with the health plan that person, who's responsible for them, and try to then partner with that health plan to convene the different system partners involved in that person's care. There are various clinics. Sometimes it's law enforcement if they're, sometimes y'all are the ones seeing the person the most. And then basically get, around a conversation on what's going on with this person, what needs are not getting met. And then most importantly, what are we going to do next time they come? Because whatever we did the last 5 times clearly wasn't right. So we need to figure out a different plan. These are sort of the people outside the bell curve. So what was working for the 99% was not working for these folks. And so so that's what we've been doing that program for quite a while. We've actually when we first started it, we actually published a paper showing the decrease in repeat visits and decrease in quote that revolving door. That said, there are also the study that was done that is linked in the press release also looked at when police bring people to the CRC for their first deflection. Some of them, they tend to come back, and they come back and they stay longer each time. So in that case, if it depends on what lens you're looking through. If you're looking at that purely from a health plan point of view, you're like, oh, they're a high utilizer, they're coming back. But then if they're coming back to the CRC because they're not going to jail, then that is actually a positive outcome. So for sometimes you have to look at the whole picture to see, well, I'd rather that if they're, that data suggests that perhaps we're engaging with them, and maybe when they were not quite motivated to continue on with some of the treatment that was recommended, but as they come back, they get more engaged, then that's actually a good thing because the alternative is jail. So, so data is complicated sometimes, but yes, looking at people coming back is definitely, a huge part of what we do.
Thank you so much. I think we're going to try and flip over to some of our questions now in the Q&A, and we're going to get through as many of these as we can. However, I want to, any question that we're not able to answer or answer as completely as you would like, I will make sure that every single question gets addressed. So if you will send us an email to justiceservices@pima.gov, if we can't answer it here, we will forward it over to our panelists for further discussion. So please don't be shy about reaching out, because we want to make sure that we get your questions addressed. So I think the first question was included in one of Margie's responses. And so I'm moving on to the next question regarding the jail. And the question is, given the high number of deaths in the Pima County Jail over the last year plus, do diversion deflection tactics include flagging people who may be substance dependent and medically vulnerable, even if they don't qualify for diversion and will be sent to jail? What else is being done to address jail deaths besides lowering the jail population? So there's a lot to unpack in there. Is there a formal flagging of individuals? That mechanism does not exist. Certainly, each of our various law enforcement partners have their own type of data system, and Tucson Police Department does have quite a bit of history with individuals, certainly those who have had contact with our MIST and CERT teams, but there isn't a universal system across the board that will flag somebody. Now, when somebody comes into custody, there is also, if they've been in custody before, there is a history associated with that individual as well. One of the things that we are doing here in Justice Services is we coordinate the Jail Population Review Committee, and obviously we can't do the entire jail population, but what we do is identify individuals who are likely to be released back to the community anyway. These are individuals who have low-level type offenses. They have most reliably a substance use, mental health disorders, and they are probably going to be getting out in a couple of weeks to a couple of months, and keeping them in custody longer is not doing anything to make the community safer, and it's not doing anything to help them. We work with a whole system of folks. We have prosecutor, public defender, pretrial services, adult probation. We have housing providers, treatment providers. The MIST teams participate. And what we try and do is once we identify these individuals who we can expedite their release, we also do this warm handoff. We utilize MacArthur funding to provide housing for every single person who does not come out with housing. They have housing guaranteed for at least 3 weeks. And we help arrange for things like a cell phone. If somebody comes out and doesn't have the ability to contact pretrial, doesn't have the ability to contact treatment, we provide a cell phone for them free of charge that will be able to communicate with all those various resources. And we also identify individuals at that point who are of high risk of overdose, and every single one of those individuals receives Narcan when they walk out of jail custody. And we work with a number of different community systems to distribute Narcan as widely as possible. So we're trying really hard to do our best to stop those individuals who are coming into custody who potentially have, these substance use disorders, as long as they aren't presenting a risk to the community. I mean, certainly when those folks are in custody, there are multiple measures that I won't have enough time, unfortunately, to get into today. But we're also trying to be proactive in preventing those folks who are at higher risk when they are coming out as well. The next question is, are officers within the Pima County Sheriff's Department given the same access to crisis intervention training? And that is a resounding yes. They are not only given access, they are our equal partner. I've been one of the facilitators of the crisis intervention team training, CIT training. For those of you who are not familiar with it, it's a 40-hour volunteer-only crisis responder, and this is a supplement to the mental health training that every police department, every officer gets in our community already. Most departments mandate mental health first aid training for all of their staff. Certainly the Sheriff's Department and TPD does. CIT is a specialty responder. They are self-selecting to respond to people in crisis, and we load them up with 40 hours of training and practice talking to folks who are in crisis. The Sheriff's Department, from the very first CIT program that we have had, which was back in 2002, so we are at our 20-year mark, and they have been our partner in this every step of the way. And there is a lot of collaboration that happens between Tucson Police Department and the Sheriff's Department MIST teams. I don't know, Winsky, if you want to speak to that a little bit.
Yeah, we absolutely operate on a regional model. So we have all different departments, big and small, the suburbs. Tucson's obviously the biggest one, followed by the Sheriff's Department. And it's absolutely a collaborative effort, absolutely. I see a few more questions coming in. We're gonna, if people want to stay on, I think we have about 5 to 7 minutes left. I think we answered Kevin's first data question. And I think, so just scrolling through our Q&A here, I wanted to talk a little bit about, I see several questions here from Elizabeth. We'll get to that in just a minute. I see a long question here from Clark about that is talking about controlled delivery of substances to people. So almost like an angel type program. I want to make sure I'm getting his question right there. Margie, I don't know if you could see the question there or want to
Oh, I think
interject.
that's about safe injection sites.
Safe injection. So would you, I guess he's asking if the panelists have an opinion of those programs. For us on the law enforcement side, I think we'd have to unfortunately say that as law enforcement, we don't have an opinion one way or another. But I wonder if any of the other panelists have, maybe Margie or Brendan.
Yeah, for those that aren't familiar with that, so having safe injection sites is where some cities are setting it up, saying, well, we know that people are using, and we want to take a harm reduction approach. So like there's sort of like two schools of thought in the substance use world. Kind of the traditional view is that the goal of everything should be to help the person become abstinent and stop using. Harm reduction is a more recent school of thought, which is that people's substance abuse doesn't, like, you engage people in treatment and they're not like immediately, oh, I've been presented with substance use treatment, now I will stop using now and forever, and it's just done like that. People, it takes a long time for people to get engaged. People, they are, they will reduce their use and then they will relapse, and that's just the nature of the illness. And so there's a sort of a philosophy of, well, we want to reduce the harm that the person that's caused to that person or others. In addition, so it's not just abstinence, as we want to reduce the harm. So for example, naloxone is a great example of a harm reduction approach. So like, why would you, if your goal is to help, is for people to get into services and never use again, why would you give them the antidote to overdosing? Because like, we want to have them not use and then have a rescue drug. But from a harm reduction approach, you want to save lives. And in reality, people's drug use isn't going to flip off like a light switch. And so you give them the tool to save lives. Same thing with like needle sharing is why would you give someone needles? You're helping them use drugs. And but you also want to prevent the spread of Hep C and HIV and bloodborne illnesses. And so you give needles because you want to save lives. So sort of on the extreme of that is this idea of safe injection sites where especially now that the drugs that are out there, a lot of them, it's not just heroin, it's fentanyl and all these fentanyl analogs, and people overdose. And naloxone is one approach for that. And another approach is to have a safe place where people use and there's someone there who can help them. And so some cities are doing that. I think San Francisco, I think maybe Philly, don't quote me on that because I'm not 100% sure which cities are doing that. I've not heard of anything like that going on here, but that is what that is. It's a harm reduction approach. And I would just say that, like as far as my opinion on it is, I'm a physician, so I'm for things that save lives. So if that's one tool for a very specific population, then, I'm interested in that. And, and again, our various services are not one size fits all, and there may be a population for whom that is the way at that moment to help save a life. So that's my opinion on that.
Brendan, did you have anything to add there, or?
I mean, yeah, I have so Tucson's done very well to do harm reduction styles, right? To implement them I mean, even the police department does harm reduction, which is crazy. Some places won't even think about not arresting someone who has a felony drug warrant, but Tucson does. So if they're not a danger to the community, obviously. But safe injection sites are, I mean, I'd like to look more into all the statistics of it and stuff, you know what I mean? Coming from an addict, I'm an addict, I understand. But also that other side of me is like, oh, if I had somewhere safe to use, I probably wouldn't stop using for 40 years. You know what I mean? Would I ever want to get clean? So there's that aspect to my mentality of it. You know, yes, it's going to save lives. It's a safe place for people to use. But at the same time, are those people going to get better? Or are they just going to live longer? Like, what do we want? You know, that's my battle with it. I get the good part of it. And yes, Tucson maybe needs to do it. Or maybe not, you know, it's just a different type of harm reduction that cities have used. And if it's been successful, then let's do it. But if it's not really, you know, so if it's going to help, then let's do it. But otherwise, I don't know that it would help me. And that's all I can really speak on.
Got it. Thank you very much. I think we had a hand raised. Did the person who raised their hand want to come off of mute and ask their question? Kate, can you see who it is, or
I think
the
it was,
person still
was it
here?
Julie? So we can see the hand. Oh, I saw
Okay.
Julie pop up. Maybe we're almost
Oh.
there. Julie, did you have a question?
Wait 9 seconds for introverts.
For the introverts. Julie,
Well,
if you
then
can
I
still hear
think-
this,
Yeah.
please feel free to email me at oh, I see her. She came off of mute.
I have a question right now. I just raised my hand to ask. So,
Okay.
Feel free to
All
shoot
right.
me an email too if you want to chat more.
So Kate, I think
If we did not,
address.
oh, sorry, Jason, go ahead.
Sorry. Did you want to maybe, I can address maybe one of the Elizabeth questions and then we can give the email out. And I think that's about what we have in the Q&A. So Elizabeth asked a question about the people that are revolving in and out of the CRC. Are we tracking their criminal charges in between? The answer is absolutely yes. But what we see more in that case, whether it's like a MAC clinic or, you know, we have a place here called Kodak. When a person's revolving to those places a lot, what's happened more often is not like jail CRC. What I see more is repetitive, like every 3, 4, 5 days going to the CRC over and over again. So the answer is yes, we are tracking that. And Elizabeth, if you are in Tucson or in Pima County, I hope you are, we would like to connect with you one-on-one about some of your other questions and concerns. Kate's going to provide the email here shortly. And it sounds like you have some specific people on your client list or your caseload, and we'd be happy to find some solutions for them for sure. Go ahead, Kate.
The question to the cell phones I'll speak to really shortly, and then please, I don't have the ability to post something in the chat, so please just email justiceservices@pima.gov and we will give you more information. But the cell phones is a grant-funded project that we've done with COVID funding. It's for specific programs. So if you have somebody who is in our jail population review committee, if they're in steps court, some of our other treatment courts like Compass Court, we have phones available to you. If you have a specialized program for individuals who are in a treatment program, but they're also in a treatment court in some form or fashion, and you don't have a mechanism for these cell phones, reach out to me and we will see if we can assist you if we can. It is a pilot program that we are testing to see if it helps improve things like program retention, showing up for court, access to transportation, etc. So please feel free to reach out and I can provide more information about that. If we did not get to your question, I am so sorry, but we will do our very best to get everybody who has more questions connected with the right folks. We are very, very grateful to everybody who joined us today, who asked questions and engaged with us. Certainly, I could do this every single day of the week. Some of these questions alone are worthy of their own complete presentation. We simply ran out of time, but hopefully this is the beginning of many more conversations about this work. Thank you so much to our panelists. I'm very grateful for the gift of your time today, and everybody at MNR and Justice System Partners who supported us with this panel and the project itself. And thank you most of all to every participant who sat with us today and asked wonderful questions. We're very grateful for your time. Thanks for joining us.
Thank you so much,
Have a
everyone.
great rest of your week.